So our last award recipient of the day is Andrew Steenhoff. And I've come to know Andrew very well, and we partner on many activities. And I have to say, always a tremendous, tremendous pleasure. In fact, we were just this Monday in Washington, D.C., meeting with the Namibian ambassador to the U.S. on a new project we're thinking about optimistically. Andrew's an endowed professor of pediatrics, attending physician at Children's Hospital of Philadelphia, CHOP for the uninitiated. He also directs CHOP's, or he's the medical director of CHOP's Global Health Center, which he's been doing since 2015. And I think it's fair to say Andrew embodies the spirit, both not just of faculty, but of leadership in the institution and how we think and hopefully support all of our colleagues in developing their efforts in global health. So it's not just about Andrew, it's about what Andrew can do for everyone else. And I think he thinks of that long before he thinks of himself. Andrew received his medical degree at the University of Witwatersrand in South Africa. This was followed and developed his interest in pediatrics there. This was followed by time spent at the Royal College of Surgeons in the United Kingdom, the College of Medicine in South Africa, and then here in the US at Albert Einstein Medical Center, where he did his residency in peds, and then his fellowship in pediatric infectious disease at CHOP. I think the number is bigger than what I'm going to say, but Andrew has worked over 35 plus years in 5 different continents and 21 different countries, not just visited, but worked. And this encompasses so many different components and attributes and work in the global health space. But I think the key grounding feature was the time he spent with us in Botswana, where he was the head of research, the director of research at our BUP office, which is the Botswana-Penn Partnership, which is a constellation of efforts between both Children's Hospital and Penn, working in Botswana. Ellen just presented Farouk and the team, and you heard from Owen as well about that effort. When he left Botswana, he brought with him just this world of experience and continued his work. And I know he'll say something about this, that as an infectious disease physician that began in Botswana, focused around HIV, diagnosis, prevention, care, or I should say prevention, diagnosis, and care. That has manifested over time as Botswana has done a spectacular job in their HIV program, thanks to Andrew and many colleagues at Penn and around, and Robert's here with us, for example. And that has morphed more recently into sadly, those other, things that we have to think about. So his tuberculosis as well, which he also began there and continues there to this day. So he's back and forth, even though he's based here now, primarily back and forth to Botswana quite frequently. This year, and we do this every year, we focus our faculty awards with a different kind of emphasis theme. And this year's emphasis was really on individuals who were not just great clinicians and great educators, and not just great mentors, but were team builders. And I don't think there's a better representative of that than Andrew. So, Andrew, come on.
Thank you very much, Glenn, and thank you to the Suskinds. It's a great honor to be here today. As I've shared with many of you, I feel like a team captain who's receiving a trophy on behalf of a big team. And the team at the CHOP Global Health Center, thank you to all of you and to everyone across this amazing campus. And thank you to our first 2 speakers who were phenomenal. Much appreciated. So briefly, I'm going to talk about 4 stories, and you can see pictures of these stories here. So by the end of our time together, you'll have a sense of how global health ties into these 4 pictures. I'm going to speak a little bit about the state of the world's children. Some of us are in pediatrics, others are not. A bit about the power of partnerships. We're in this incredible time where we work in an academic medical center. What can we do to advance child and global health? What's the secret sauce, though, to these partnerships? And then a little bit about impact. So in 2020 alone now, speaking about the state of the world's children, 5 million children died before their 5th birthday. This means that in an hour, 570 children died. So today, in the 2 hours that we together, over 1,000 children would have died in 2020. So this is a lot of deaths, and it's something that we need to be thinking about as a global community. What are we going to do about this? But what is killing these children? Why are children dying globally? And this report from UNICEF and the WHO was published in The Lancet. And it's a pie chart showing all the causes of death in children. And I'm going to take you to the 2 areas that I've circled in red. Top left for you, 1 to 59 months, and then top right is neonatal deaths. You can see that neonatal deaths, so this is deaths in children under the age of a month, account for 46% of the deaths of children under 5. So this is an important statistic because the first week of our life is our biggest risk week in our whole lives. And globally, if there's one place to focus on, it's really on that first month to try and prevent deaths. And you can see all the causes of death in newborn babies in yellow, and then the other causes on the other side. But let's look at them in a bit more detail. And now what I'm highlighting is all the causes of death that are caused by an infection. So I'm really glad that Owen's thinking about infectious diseases. So you can see TB, lower respiratory tract infection, sepsis, meningitis, and it goes on. AIDS, malaria, measles play a major role in infections in children as a cause for children dying under the age of 5. And so you might ask me, well, how important are infections? Can you put a number on it? And the answer is they're big. Infections cause 43% of child deaths under the age of 5. So if there are med students out there or if they're residents and you're thinking of how can I make an impact on global health, consider infectious diseases or consider fields that deal with infectious diseases. You might ask, well, what is the under 5 mortality rate like around the world and how does it vary? And this figure shows us from UNICEF what the rates are like globally. Dark is bad. So dark rates means lots of death. And you can see, unfortunately, that sub-Saharan Africa has got the highest rate of deaths, as well as East Asia, Southeast Asia. Those are the 2 big areas. And then you can see here, I've done a little pull-out of a small island in the Caribbean, Hispaniola, which consists of the Dominican Republic and Haiti. And really the rates of child mortality, unfortunately, in the DR and Haiti are somewhat similar to sub-Saharan Africa. And that's part of the reason why CHOP chose to do a partnership in the Dominican Republic. So the deaths are occurring in sub-Saharan Africa and Southeast Asia. So where's the care? Well, this is a map showing where the doctors are. And here, dark blue means lots of doctors, and green or no color means less. And unfortunately, we can see that there's a reciprocal relationship. There are very few doctors in sub-Saharan Africa, and there are relatively few in Southeast Asia. But we all know that really it's about the nurses and the midwives. If you've got great nurses and midwives, you need a few doctors, but nurses and midwives are more important. But unfortunately, the story is the same. The number of nurses per population, again, much, much fewer in sub-Saharan Africa and Southeast Asia. So our little summary at this point is the state of the world's children could be summarized as there are a lot of children dying, 1,000 kids may be dying roughly in the time that we're together, that newborn deaths or neonatal deaths account for almost half of deaths under 5, that infections are a big player. There are other things too. And then where you are born counts, both in terms of risk of death as well as who's going to look after you or who may not be there to look after you. So let's start here with Thandi, this mother who's looking lovingly at her child, Thandeka. This little child is 4 months old, is breathing fast, and has got pneumonia and is admitted to a hospital in Botswana. Now, pneumonia is a very dangerous condition. It's one of the top causes, actually, of death in children. And it's an important one for us to address globally. And the question is, what's going to happen to this little child? Is she going to survive? Is she not? And we have a group here illustrating the power of partnerships. Morgan Congdon, who is a CHOP resident, or was a CHOP resident, and is now a faculty member at Penn, along with Mamiki Chise, who you can see top right, who was a resident in Botswana at the time, now a pediatric oncologist. Francis Banda, a faculty member at the University of Botswana, and Matt Kelly, a former Pincus fellow, who's now a PEDS ID doc. And what this team decided to do with a number of other colleagues was look at pneumonia in Botswana and try to see what was going on. What's the death rate like? And importantly, what was the impact of what the Ministry of Health had done? The Ministry of Health in Botswana wisely decided to introduce vaccines, the pneumococcal vaccine and the Hib vaccine. And all ministries of health have to make tough decisions. Do you provide surfactant or do you do vaccines, for example? And so this team, working with the Ministry of Health, decided to look at this and see what the answer was. The good news is that after the introduction of Hib and pneumococcal vaccines in Botswana, there was a 50% decrease in pneumonia deaths in Botswana and a 48% decrease in pneumonia hospitalizations. The great news is they were able to present this to the Ministry of Health and say, well done, this is fabulous work. The ministry has continued to fund this vaccine program. Their leader in health is a different person to the person we currently have. And their immunization program continues with passion. They were also able to write this up in a manuscript, and this has informed World Health Organization guidelines as well around the world. So the WHO is prioritizing encouraging countries around the world to roll this out at scale. So global health partnerships can do research that influences policy that saves children's lives. What about this picture? I showed you this earlier. You can see this is a gentleman called Dr. Madan, a senior pediatrician. He's teaching young doctors, including the first Pincus fellow, the tall guy, on second from right, Henry Welsh, up in a hospital in Francistown in Botswana. You can see it on the map. And there are a number of young doctors around Dr. Madan, and they're learning how to read a chest x-ray. This is a child who's got tuberculosis. Fantastic. This is what we do in clinical medicine. We teach those coming behind us, and then one day we say, I'm off on vacation, and now it's your turn to take it over, and hopefully you've learnt. That's all great. But what I want us to look at is something a little bit differently about this picture. What I'm doing here in the bullets is giving you a sense of where each of these young doctors trained in 2010. This young gentleman on the side here moved from Botswana and went to train in China, came back to Botswana. This young lady at the bottom went to Norway, learned Norwegian for a year, came back, did medical school in Norway and came back to Botswana. And you can see that young gentleman far left in South Africa, Henry trained in the US, and then the gentleman in the middle with the glasses on trained in the Caribbean, and Dr. Madan himself trained in India. And this is what Botswana was like when we as Penn started working in the country. Botswana would send their brightest med students or brightest students out, and many would come back, but only a third would come back from different parts of the world, and the rest would stay where they'd come from. And this was what it was like. And the government of Botswana said, we need to do something. We need to start a medical school. So partnering with Penn and with a number of other organizations, that's exactly what they did. So we were fortunate, I think, as Penn and CHOP to be able to partner. A new medical school was started in 2009, 2010, and there have been more than 500 med school graduates now with a number of residency programs, including in pediatrics. And so we can now relabel this picture in 2026, and this is what it would look like. When I go back in a couple of weeks, Robert's just returned. When we do rounds now in Princess Marina, not all, but many of the doctors have been through the University of Botswana system. And yeah, there might be the odd visitor from the US or elsewhere, and certainly there's still really outstanding doctors from other countries playing a role. My point here is that global health partnerships can play a major role in medical education to transform health systems. And this is what's happened in Botswana. What about this picture? This is a picture of Thuso, and Thuso is sitting in one of the rooms of Princess Marina Hospital, all the red roofed buildings of Princess Marina Hospital. It's a picture from a drone, perhaps. And little Thuso has just had his appendix out, and we've got, I know, a few surgeons in the room. Post-appendix, he's on antibiotics, he's looking better. And the question is, how well is he doing from an antibiotic standpoint? Are we giving him the right antibiotics? What's happening? Because antibiotic use, and particularly antibiotic threats and antibiotic resistance, are a major issue in global health. So again, working with the partnership model, one of the fellows at CHOP in ID, Ima Kit, who's shown here, worked with Lueto Majani, who at the time was one of the leaders in the pediatric department, to assess antibiotic use in both the peds medical ward and the peds surgical ward at Princess Marina. And the answer was, unfortunately, that appropriate antibiotic use, as defined by the World Health Organization, was 0% on the surgical side. That's a bad number. And that means too much antibiotic, too strong, or antibiotics not given. And I'm not looking at any of the surgeons, and this was a big issue. As Robert and other researchers in the room know, research is important. It allows one to pick up the carpet and look what's underneath. But it's not just about picking up the carpet. You've got to do something about what's under that carpet. And so next up, enter Dr. Bedada, top left. He's one of the associate professors in the surgical program at UB, the University of Botswana. And he said, this is unacceptable. We need to do something and we need to fix this. And so he reached out again to Ima and to others in the team and said, we need to do a quality improvement project. I haven't done one before. Can I work with you guys? Let's see what we can do together. And so he brought the surgeons together. They created 10 pathways for the commonest conditions: appendicitis, a urinary tract infection, brain abscess, and a couple of others, and said, this is what we're going to do. They agreed as a group at Princess Marina, and they implemented. And there was guidance for the junior staff, for the nurses, and for the attendings. And appropriate antibiotic use was measured for 9 months after implementation, and impressively, it went up 90%. Again, the power of partnerships, incredible colleagues, as we heard earlier at Princess Marina, but also someone who wanted to learn how to do quality improvement work. So we were privileged to be part of that. What about this lady? Let's call her Angie, and we'll call her baby Angelie. People understand the joke because we have a fellow in the DR called Angie, whose baby's Angelie. So when we first started working in the Dominican Republic in a rural town of Consuelo, we looked carefully to see what the rate of breastfeeding was. And the top two pictures here, I'm sorry, it's not a great picture, but this is Ramona and our first fellow, Lara, Pincus fellow. Lara herself was a young mother. She knew how important breastfeeding was. Ramona's a dynamic community nurse, and she knows that it's about immunizations and breastfeeding and a couple of other important things. And they found that the rate of breastfeeding initiation in Consuelo was around 10%. We said, oh, this is terrible. What's going on in Consuelo? What is the rest of the DR like? And we were just exactly at the national average. It was 10% in the DR. When you drive around the Dominican Republic, you see big pictures of fat babies with formula. And there's been a whole cultural shift through advertising, etc., that really the way to go is formula. And so this was a really sad state. And so what happened is Ramona, Lara, and others developed a health promoter program in the community, worked with Lalesh League and others, and really promoted breastfeeding in this town. And below these two is Angelie, an undergrad student here at Penn, who joined us to do this assessment, and Dr. Happa, the general pediatrician who worked with us for many years. And they did an assessment with others of how the program was going in 2023. And wonderfully, through all the hard work of the health promoters, Ramona and many others, the rate of initiation of breastfeeding in Consuelo has now gone up to 90%. So we've now shared these data with the ministry as well as put it out and published it. Point being, global health partnership can make a difference when we work with the community and we work with amazing local community experts like Ramona. And my last story may be a slightly surprising one to you. It's just an arrow from somewhere to somewhere else. And that arrow is roughly from Botswana to Philadelphia. And I put this arrow up just to put out the concept of reverse innovation. As Glenn was alluding to, Botswana and many other African countries have done a phenomenal job from a public health standpoint and also from a science standpoint with certain conditions such as HIV. And so what Botswana found through really high-quality studies published in the New England Journal was that if a mother's got HIV or she's HIV infected and she is well controlled on her medicines, she can breastfeed her baby safely. We have this U equals U thing, which is if HIV is undetectable, then then it's untransmissible. And so Botswana, as long back as 16 years ago, 2010, started data-informed approach of you can breastfeed, please go ahead. And breastfeeding, as we know, has got lots of advantages, including adding a few IQ points, which we can all do with. And so, ironically, we in the US have been a little behind on this. But the good news is that Liz Lowenthal, our research director, who was part of this initial move in Botswana many years ago, has now, with other colleagues in the US, moved the needle. And so the new US guidelines are now the same as they are in Botswana. So mothers can now choose in Philadelphia and around the US to breastfeed if they wish with these new data. And I think as we as a global community get closer, despite what some would tell us, we need to be aware of this concept of reverse innovation. We can learn from each other, no matter where we're from or where we practice. And I think we do ourselves a disservice if we're not open to the amazing creative ideas of our colleagues in low and middle income settings. So my mini summary too is that global health partnerships can advance child health using many different strategies, no matter what our skill sets are as academicians. They can do so in research through the pneumonia study, medical education through helping Botswana or other places get their training programs to the next level. We can help with quality improvement work, such as the antibiotic example, community engagement and public health, such as advancing breastfeeding and other relatively low-cost interventions that have major impact. And then we need to be open to and gratefully receive reverse innovation when we go to learn as well, because we will. So what's the secret sauce to these partnerships? You know, this sounds all so easy. Why don't we all just go out there and do it? And obviously, when I'm speaking to the converted here, we are all involved in one way or another. But I do think it's important for us to be thoughtful as leaders, facilitators, people stepping into this field to think about how this can be done and how it can be done well. And so the first brief point is practice and principles. These are 4 core practices that I do think are helpful in global health partnerships. And I think they're helpful in most partnerships. I think my wife and I use them in our marriage as well. Communication, certainly leadership, and it's obviously leadership here at CHOP and PEN, but also leadership in partner countries. Conflict resolution. I always joke with Maji Rankin, he's at the back, and one of my amazing colleagues in the Global Health Center, that I really feel we're making progress in a partnership when we have a good disagreement and we are able to leave still as friends and partners. Because the ability to have conflict resolution and to do it well, I think is a critical component of successful partnerships. And then evaluation. And I think part of evaluation starts at the beginning. What are the metrics that we all want out of the relationship? And let's measure them as we go along. And then these are our 7 guiding principles of global health partnerships that were put together by a group of pediatricians from 10 different countries, which I think, again, are helpful to consider. We need to have partnerships that give mutual benefit. It doesn't have to have the same benefit, but there needs to be some benefit to all concerned. We need to be operating in humility as best we can. We need to be thinking about sustainability from the beginning. There needs to be inclusivity of everyone, everywhere. We need to prevent adverse impact. Sounds obvious, but sometimes we go in well-meaning. You hinted at it, bringing the POCUS machine. You were creating a sort of green feeling as people envied that. We need to be aware. Sometimes we might we might cause adverse impact. There needs to be a social justice lens through which we're working. And finally, we need to, wherever we can, bring equity. We have some resources to bring. Our colleagues have others. Let's bring those together. And so this was written up, as I mentioned, in pediatrics almost 10 years ago, and I think is a useful framework and one that we try to use as we build partnerships at CHOP and at Penn. But it's not just about that. We also, I think, need mentors, and I've put pictures of some of my mentors on here, some of my sub-Saharan African mentors and many of my Penn and CHOP mentors, and I thank all of them. They've done many different things for me. They've coached me along the way. They've given me skills, and I think we, as we benefit from our mentors, so hopefully we too in time can become mentors to our partners around the world. So I think mentorship is a key part of global health partnerships as well. And then institutional commitment. I think we heard from the Suskins how impressed they are with the progress in the Penn Center of Global Health, and I agree with them. I think the Penn Center of Global Health is doing brilliantly, but we need institutional commitment. And I show this at CHOP because when the CHOP Global Health Center was created almost 20 years ago, it was many of these folks who made that decision. And the CEO, the chair of pediatrics, Rodney Fanal as the first director, who were key folks. And then for me personally, Harvey Friedman played a key role in drawing me into the Botswana-UPenn partnership, and I think laid a good foundation for many of us who've worked in Botswana. But we must remember that leadership changes, and leadership changes here, and it changes there as well. I often hear from folks, oh, it's changed in Botswana or Ghana, etc. And that's true. But we also have change in our leadership, and we need to ensure that institutional commitment continues. It can change, but we need to ensure that we keep the best part and then are open, obviously, to changes that enable us to throw out things that aren't working. So I'm obviously using CHOP as an example here, where you can see the transitions. The top left is Paul Offit, the division chief of ID 20 years ago, and now it's Audrey Odom-John, both very committed to global health. And you can see many of the other leadership here, our new chair of pediatrics, Jordan Orange, etc., and obviously Glenn, a key leader with Farouk of the Botswana-UPenn partnership. So I think we've been fortunate, and I just wanted to acknowledge that to this group, that we've had excellent leadership and we've had committed leadership over the long term, and we appreciate that. And then, of course, it's not just about our institution, but we need to look out. And so I wanted to thank the funders who work with us. Danielle, I'm going to ask you just to wave, if you don't mind, as the leader of the Pincus Family Foundation. The Pincus Foundation has been our core funder at the CHOP Global Health Center, and without them, much of what I've mentioned wouldn't have happened. But there are many other funders who are on this list as well, federal funders, foundation funders, and then I've also put many of our partners here too, from Ghana, from Namibia, from Botswana, from the Dominican Republic as examples, because global health truly is a team sport. So what's the impact been of these partnerships? I've given you some nice examples. As Glenn mentioned, I've been involved in this for a while. I'm sure I could find something good to say. But let's be a little more objective. What's happening globally, and are children's lives being impacted positively as we take the longer view? And so children who died before their 5th birthday globally in 1990, the number was 1 in 11. That's a lot. So it's almost 10% of children who were born globally died in 1990. It's pretty hectic. What's happened since then? So in 2024, the number is now 1 in 27. So it's gone down to 3.7%. So it's more than halved. This is incredible. And obviously, this is just one number reflecting so much work by so many all across the world, government level, et cetera, et cetera. But my point is, child health has improved. We're going to see what happens over the next year or two. There are concerns that this may go in the wrong direction because, as we know, funding has been reallocated by many countries, including our own. So we need to keep measuring because we really need to be focused on the global health of everyone, but particularly of children. So we've spoken about the state of the world's children. I've just given you a little snapshot. We've spoken about the power of partnerships to have impact in many different ways. And you can choose whatever it is that you do, there's a way to make a difference. We've spoken a little bit about some of the secret sauce of partnerships and how to make them work well, and then a bit about the impact and a little cautionary tale that we need to watch this space. So to end, I'd like to end with a quote from one of my heroes. Nelson Mandela mentioned that the true character of a society is revealed in how it treats its children. And I'd like to invite each of us to either continue or to consider engaging with me and with many others to continue to advance both child and maternal and family health around the world. So before I say thank you, I wanted to acknowledge my wife and family. My wife is here in the front row. So she's still with me 25 years later. I just wanted to thank her for all of her support. As all of us know, in academic medicine and particularly in global health, it's a family commitment. I wanted to thank her and my son for their support during my career to date. So thank you all.